Hello, welcome again to our program, Surgical Pathology, Digital Slide Review and Sign Out. I am Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. And our program is a joint venture between the Digital Pathology Association and Path Presenter under the Digital Anatomic Pathology Academy. In this program, we'll take a couple of interesting cases, somewhat unusual, and discuss some of the various aspects of that, including differential diagnosis and so forth. Our case is a 45-year-old woman who has an adnexal mass and also is found to have a history of Peutz-Jeghers syndrome with some mild cutaneous, mucocutaneous pigmentation and a history of GI polyps. Well, let's take a look first, though, at the clinical picture. What do we do with an adnexal mass in a middle-aged woman? Of course, at a younger age, you might think about infection, could still happen at an older age. Cystic lesions, peritubal cysts, endometriosis, those are all possible, but becoming less likely, less frequently encountered as patients age in this situation. And then you want to think about tumors. Now, of course, the most common lesions are ovarian tumors, teratomas, and so forth, all the other things down the list. But when we think about tumors that are actually separate from the ovary, and I believe in this case they were able to radiologically distinguish the lesion from the ovary, then we start thinking about a different set of tumors. And that can include some serous tumors, of course, primary peritoneal or extraovarian or tubal orange. The fallopian or female adnexal tumor resembling a possible Werfelian origin, the Fatwa tumors, mesonephric tumors, these can all occur in an adnexal location. The STK11 adnexal tumor is what we're going to be talking about, and mesothelioma, metastatic lesions also enter into the differential in this location. So here's a representative image of the case. You can follow along on your own phone if you'd like to scan that code and take a look at the slide right away with me. So the lesion, as you see here, a fairly cellular tumor, somewhat discohesive in areas, breaking apart a little bit, some cords of cells, a few vascular structures, maybe a few follicle-like structures, and sort of a loose background, a little bit of kind of myxoid matrix, very epithelioid-appearing cells with enlarged nuclei, fairly rounded, prominent nucleoli, some degree of cohesiveness, though not really organized into any structural glands or other sorts of things that you might expect. And as we look at the nuclear features, there are some macronucleoli, and there's even a few cells that may have a few inconspicuous grooves, which you can see in a couple of cells here and there in this image. The lesion has some areas which have a slightly different morphology, as you can see here, a little bit more spindle-shaped appearance, a little more streaming of the cytoplasm, and a delicate vascular background in this situation. Here we can see towards the edge of this lesion a little bit more, maybe a bit of nesting type pattern, but not really sharply defined in this area as well. So the immunohistochemistry becomes useful in a situation like this. We found our tumor to be positive with a number of markers, including estrogen receptor, also with cytokeratins, and a couple of stromal markers. Inhibin and calretinin were positive. And in our case, it was GATA3 negative, TTF1 negative, PAX8 negative. So this is a rather distinctive immunophenotype and denotes the STK11 adnexal tumor. So what does STK stand for? This is the serine threonine kinase 11, which is a tumor suppressor gene. And so not surprisingly, abnormalities in that locus lead to the formation of tumors, and this is one that has been fairly recently recognized. The picture here indicates that sometimes this myxoid background can leave you with cords or trabeculae, sort of a cystic or pseudocribiform type of pattern. But there also can be solid growth, nests, columns, whirling tumor cells, maybe a glomeruloid appearance here and there, even viloglandular fronds and pseudopapillary or pseudofollicular structures can be seen as well. So this is quite a heterogeneous morphology that can be seen with this lesion, and thus can easily be, put into another category or not recognized because it's quite diverse. There's usually not a lot of pleomorphism to the cells, and they have a very fine eosinophilic cytoplasm and so forth. Prominent nucleoli, and we mentioned that the nuclear grooves are rather inconspicuous. So because this is an unusual tumor, I've got another example here for us to take a look at under the microscope. And here we can again see different patterns here with sort of nested and abundant sort of myxoid matrix in the background, a little bit of pseudotrabecular type of pattern. But then we see also varying small structures here. And on this other fragment, notice that we have more eosinophilic cytoplasm. It looks slightly different, more abundant cytoplasm, a little bit more nested appearance. Can almost look like a different tumor in this situation. But melding into the stroma a little bit here, again with sort of pseudofollicular, small papillary structures and so forth. So allow you to study these cases at your leisure by clicking on the link in the description. I'll bring you back to these slides and you can take your time with them. So let's think about this tumor suppressor gene and what sort of tumors we are likely to see. We've mentioned this Adnexal tumor, which is the seminal case here. But this lesion can also be associated with the sex cord tumor with annular tubulars. It's been associated with minimal deviation adenocarcinomas of the cervix and potentially the precursor lesion. And also it appears that it may have an association with some endometrial carcinomas, as the incidence of endometrial carcinomas in patients with a germline mutation in this gene are somewhat above normal. Though not perhaps as high as in other endometrial cancer syndromes like Lynch syndrome and so forth. The tumor has a relationship with Peutz-Jeghers syndrome, and in fact, germline mutations of this STK11 LKB1 are observed in more than half of Peutz-Jeghers syndrome patients. The other half of patients with Peutz-Jeghers syndrome with no familial medical issues or family background may have other mutations that are sporadic or just not identified. And as we look at the types of mutations that are present here, these can be both missense mutations or deletions, duplications, nonsense insertions and so forth. And you see here they cover a variety of the different exons in the STK11 gene. So the relationships of this to Peutz-Jeghers syndrome are certainly strong, but not universal, and certainly are related to the tumors that we're observing here. On the other hand, if we take a population of patients who have this tumor and think about what sorts of diagnoses they may have been filed under or looked at or categorized as before we recognize this tumor, this would be the place to start looking. We've mentioned the female adnexal tumor, probable Wolffian origin, certainly recognized in this location. But that tumor doesn't usually have a myxoid matrix. It also is usually negative for estrogen receptor. It may have androgen receptor, and is usually positive with GATA3, whereas the STK11 tumors may have some patients positive with GATA3, but not very strongly. Sex-cord stromal tumors, they can have some common markers, the calretinins, the WT1, et cetera, but they're usually positive with FOXL2, which is entirely negative in this tumor, and often have DICER1 mutations rather than STK11 mutations. Additionally, they would usually be EMA negative, whereas the STK11 tumor is usually EMA positive. Mullerian carcinomas and endometrioid carcinomas, of course, we recognize those with some frequency, and those usually have clear-cut glandular formation and have other markers, other tumor markers that would be more typically recognized in that setting. Mesothelioma can also have some appearance like this with epithelioid component, but usually has other more diffuse growth elsewhere that could be recognized. And other mutations like BAP1 and CDKN2A or B would also be seen more frequently in mesothelioma, but it could be a challenging differential in some settings. Mesonephric adenocarcinoma, again, usually has a glandular or tubular pattern. It can have some cross-reactivity, but usually does have GATA3 and PTF1. Hormone markers are usually negative in that, though PAX8 can be strongly positive. And then we've mentioned rarely ovarian adenoid cystic carcinoma, which can have that myxoid mucinous matrix, but usually has more of a dual population of cells with the epithelial and myoepithelial type of markers. So that's a nice little rundown of some of the histologic differential that you might encounter in dealing with this tumor. So our final sign-out diagnosis on this case was the STK11 adnexal tumor, and in a patient occurring in a patient with Peutz-Jeghers syndrome. Well, I hope that you enjoyed that little run through on these cases, a little New Year sort of case to celebrate. If you liked it, please give us a thumbs up and hit that subscribe button so that you'll catch our future releases on the channel. I've also included a couple of links to other related topics that I've done in the past as well, so you can catch those. And I also have at my channel site a number of useful playlists. If you're interested in ovarian tumors or gynecologic tumors or just general surgical pathology, you can catch some of those there. So again, thanks for joining me. And until next time, we'll see you.